common standard practice at the time. Luckily, you just don't see that many cases where you have neonatal alloimmune thrombocytopenia and hemolytic disease of the newborn occurring in the same baby. Now I want to shift gears and go from a nice innocent baby to this gun-toting adult. And I got this phone call on around 2 a.m. on December the 26th. And the blood bank had been notified that we had a level 1 trauma. They were told that 3 males with multiple gunshot wounds were all being brought to our emergency department. At that time, we were identifying our trauma cases by letters, and so they were identified as trauma I, K, and S. As our massive transfusion protocol is, we immediately issued 3 sets of Group O Rh negative red blood cells in 3 separate coolers for the ER to have when the patients arrived. As soon as we delivered those, we got a phone call saying that patient K was badly hemorrhaging. You need to send up 7 more additional Group O red cells. We don't have time to get you a sample to do the blood type. So we did that. And then a little later, blood bank called ER to ask for a status about the patients, and they said, well, trauma I patient was actually diverted to another hospital because we didn't have enough operating rooms available. Trauma K was in transit to the OR because he was hemorrhaging so briskly, and trauma S was still in the emergency department. So the blood bank requested specimens on trauma K and trauma S so that we could get a regular blood type on these patients. We wouldn't keep giving out Group O negative, which is always in short supply throughout the city. And at that time, ER informed the blood bank that one of these patients had died. And we knew that patient I had been diverted. We heard that patient K was going to the OR, so we assumed patient S had died. So we got a specimen for trauma patient K, and we typed it as Group A positive. And then we sent 4 A positive red blood cells to the operating room for the patient that we presumed was trauma K. Shortly after we sent those specimens up to the OR, an anesthesia resident arrived at the blood bank window down on B level and had a specimen in his hand that was labeled not as trauma I, K, or S, but it was labeled trauma OR9. And they said we have to have 6 more units of red blood cells stat. So we assumed this was the same patient we got in the specimen before, and we issued 5 more A positive red blood cells, and we labeled those as trauma patient K. About the same time as the resident left the blood bank window to go back up to the OR, we got a stat blood gas specimen from the OR, but this one was labeled as trauma S, and this is the patient that we thought had died. The blood bank looked at the label and felt that it had been mislabeled. And so they immediately notified the blood bank that we thought we had a mislabeled specimen that had been written over, and then also that there was a very critical hemoglobin of 5.8. So we took that blood gas specimen and we typed it, and it was Group O. And we'd already issued Group A units to the OR. And the units that we gave to the anesthesia resident were also Group O. So we immediately called the OR and said, stop all transfusions. We think there's been a misidentification. But before we even got the call in, they'd already given 1 1/4 units of A positive red cells that we had set up for trauma K, but they actually were transfused to patient trauma S. And trauma S's blood type was Group O. And so the problem with that is when you give somebody that's Group O, Group A cells is, you have a person that's Group O, well they have anti-A and anti-B in their plasma, and if we give them Group A cells, that anti-A binds to those cells, immediately causes them to agglutinate and hemolyze. So this is the worst scenario for causing an acute hemolytic transfusion reaction, is giving Group A cells to a Group O person. So what happened to trauma S? Well, he was a 33-year-old male. He had 5 gunshot wounds to his chest, his abdomen, his arm, his thigh, and his spine. He also had lacerated his liver and his diaphragm. And he was transfused with 16 units of red cells, 8 fresh frozen plasma, 4 units of platelets, 10 cryoprecipitate, and we also gave him the magical recombinant factor 7. He had very abnormal vital signs, but it was hard to say whether this was due to the hemolytic transfusion reaction or just his gunshot wounds. And so I still don't know how much damage this transfusion reaction did, just because he was in such bad shape anyway. But we went ahead and did a transfusion reaction workup. This is what his plasma looked like when we got it. I don't know how you can see that back there, but it was the plasma. You couldn't tell the plasma from the red cells. It was just dark brown. And it took about 4 hours for it to start to clear out and for him to hemolyze all those incompatible red cells and clear the hemoglobin. So what went wrong in this case? Well, we didn't have a clerical check of the patient in the operating room. We didn't have a wristband on the patient. We never received written orders for blood. We were doing all this verbally. We had an unlabeled and a mislabeled specimen. We had the transfusion tag on the units that were returned had been cut off the bags. And the anesthesiology resident was pressuring the blood bank technologist to hurry up and release blood because the patient was bleeding to death. So all these things together, I think, led to the situation where we didn't follow our standard protocol and we gave the wrong unit of blood to the wrong patient. And since this happened, this is a couple years old, we put in a lot of other measures now, and luckily this has never happened again. As far as trauma S's outcome, he was hospitalized for a total of 32 days. He had multiple operations. He had complications of pneumonia and a wound infection and had a paraspinal abscess as a result of one of his gunshot wounds. He was eventually discharged. He was ambulatory on crutches. He has a permanent neurological defect in his leg. He went home on antibiotics, and I just kind of felt between the gunshot wounds and the hemolytic transfusion reaction, he probably expended 8 of his 9 lives. So as far as an acute hemolytic reaction, this almost always occurs because we give the wrong unit of blood to the wrong person. Usually it's an ABO incompatibility that causes the problem. I mentioned earlier it occurs in about 1 in 38,000 units. We transfuse about 7,000 to 8,000 units of red cells a year at St. Luke's Hospital, and we get one of these reactions about every 3 or 4 years. So it's almost exactly what this national statistic is. 2/3 of the errors on a nationwide basis are due to identification errors, either involving the patient, the blood sample, or the blood component being mislabeled. And 1/3 of them are due to errors in the transfusion service as far as mistyping the unit or issuing it to the wrong patient. 10% of these reactions are fatal. I'm always surprised that it's not a higher rate than that. I think in this case, the patient got 16 other units of blood, and so probably he was bleeding so briskly these incompatible units were bled out, and he was being replaced with compatible blood. Typically, with an acute hemolytic reaction, you see fever, chills, a burning sensation at the IV site, flank pain, anxiety, tachycardia, fever. I have fever on there twice, don't I? The important thing about fever is I think we tend to treat febrile transfusion reactions lightly because they're so common, but it's often the very first sign of a hemolytic transfusion reaction. And so I think it's important to always investigate febrile transfusion reactions. The morbidity and mortality of an acute hemolytic reaction is proportional to how much incompatible blood you give. So that's why we always say that we want to start a unit of blood slowly and monitor vital signs for the first 15 to 20 minutes. And then if everything appears okay, then you can go ahead and increase the rate of transfusion. So the reason we do that is simply we want to limit the amount of blood that's there in case this is going to, the amount that's transfused in case this is going to be an incompatible transfusion. I've seen symptoms occur with as little as 1 milliliter of incompatible blood. And then, of course, the risk of fatality gets higher when you start transfusing an entire unit. The most serious consequences are acute renal failure, shock, and DIC. And I already mentioned this is the reason why we want to start slowly when we transfuse. As far as preventing these kind of reactions in the future, it really all gets down to paying a lot of attention to patient identification protocols, positively identifying all the blood samples that are drawn for the pre-transfusion testing. We now have a policy in the hospital that we do 2 ABO blood types on every patient before we'll issue type-compatible blood. If we don't have that, we'll only issue Group O blood. That's why it's important that 2 people verify the identification of the patient and the blood component at the bedside before the transfusion started. And we just have to hold people accountable for this protocol.